We can address to the doubts in the WhatsApp group. We'll quickly move to the next session. The next session is on invasive cardiology by Dr. Subramanya Murthy sir. Sir is doing his fellowship in invasive cardiology in HMS, IISI HMS Whitefield.
We decided to keep this topic actually part of pre-lunch session because there was a request from some students that they wanted to go after lunch because they had duties. So there is another part which I'm discussing about interventional cardiology, your paper 3, which is again split between me and him. So he's discussing this part initially. Thank you.
So good afternoon. Since lunch hangs in the balance, I'll finish very fast. So all of you are familiar with the cath lab, so you know that the CR moves caudal, cranial, RAO, and LAO. So the main thing is that the biggest pitfall of angiography is that we are looking at uh, we are taking 2D images of a 3D structure, right? That is the biggest problem. So that is why we need to take these multiple views to profile a 3D structure. We need to take a LAO, RAO. So before a CM was invented, how would people take LAO, RAO? So it's very simple. So suppose I am standing in front of the X-ray tube and you want to take a LAO for me, I have to turn to the right. And similarly, if you want to take a RAO, I have to turn to the left because the projection plane will not change. But since the CM came, the patient doesn't have to, right? So that's the basic idea of how a CM works. Very important in coronary angiography or anything is that we are all looking at an X-ray, right? So X-ray is a 2D image, as I said. How do we superimpose cardiac structures on a 2D image? That is the fluoroscopic anatomy of the heart. That is what is important for technicians, because when I was learning my angiography, I was taught by technicians, oh sir, your catheter is there, you're already engaged, you're in PA. How do you know that? You know that only if you understand the fluoroscopic anatomy of the heart. So this is the PA projection of the heart. So if I just superimpose this is how the structures look like. The main basic thing is that your LAD runs on the anterior interventricular groove. So it runs between the RV and the LV, right? And the circ runs on the AV groove, the atrioventricular groove. So it'll run between the LV and the LA, isn't it? And the RCA runs just on the inferior wall. So this is the basic projection, right? So if I take another image, the same thing. So that was the coronaries. This is the arterial circulation and the LA. So if you can see, the RV is like it is like a oblong structure. So you have a RV, then RVOT, and it opens into the PA. And how is the LV oriented and how are the pulmonary veins oriented? This is how you should know, because somebody is doing a ASD, they're crossing the ASD. Many times the wire will go into the RVOT or the PA. How will you know they're in the pulmonary veins, right? So if you're outside the cardiac salute, it's the pulmonary vein. So again, as I said, how do we understand whether we are in LA or RAO? So I'm going to make it quick. Very simple is when you're looking at a projection. So suppose you're taking an LAO view of me, I'm turning to the right. So what will happen is the spine will move to the opposite side. Okay, so if this is for a cranial angulation, so whenever you have a cranial angulation, you will see a diaphragm. Okay, if you're not seeing a clear diaphragm, it is either caudal or plane projection. So as I said, LAO, so if you have to take an LAO of me without the C arm, so I'm going to move to the right. So my spine moves to the opposite side, spine moves to the right. If you're seeing a RAO projection, the spine moves to the left. Okay. So if you're seeing a AP or a caudal projection, you will not see the diaphragm. If you see diaphragm, it is cranial projection, right? So just a short thing on what is a profile view and what is an en-face view, that is we are seeing the coronaries. So an en-face view is when you're looking at me straight on. A profile view is when you're seeing me from the side, right? And how do we assess coronary segments and what is the concept of orthogonal view? So whenever we see an artery and we want to see it completely laid out, so that is an orthogonal view. So in many views, what will happen is, so that is the view where you are looking at the artery perpendicular to it. So you can see the full extent of the artery. So if you're seeing the artery in its path, you will see it foreshortened. So whenever we are profiling an artery, we should take two orthogonal views, one in its path and one perpendicular. Okay. So this is the same thing. So we are looking at a caudal image of the left coronaries. So the LAD is foreshortened in the caudal images. And you can see that the LAD, this is a cranial image. So you can see it along its path. So this is the correct orthogonal view for a LAD. So very quick, simple way to understand which coronary is going where is. So there's one article by an old professor in cardiology. So suppose you take your right hand, right fist. So this is your heart. And if you take your three fingers, so this is the anterior interventricular groove. So this is the LAD. The index finger is your LAD. On the other side is circ, and this is RCA. So if this is your hand and you want to say take a cranial projection, right? This is the LAD. So what you do is, suppose this is not a CM. So I'm going to move my hand down. So the LED comes straight. So that is the basic concept in CM imaging, that you will get LED straight on in cranial views and you will get the circ straight on in caudal views. Okay. So this is the next fluoroscopic imaging what I talked about. So can anyone tell me which view of the heart this is? So spine is to which side? The spine is to the right. So this is a LO image. So if I have taken a septal puncture idea here just to show the structure. So on top of this, if I superimpose my cardiac structure, this is how it's going to look like. So this is how the cardiac structures look like in a LO projection, roughly. And why this projection is important is that it lays out the IS and IVS flat on. It's like the 4-chamber view of echocardiography. Okay, so that is the importance of the LO view, that you're seeing the septa straight on. So it's easier to do septal puncture, or when somebody is doing septal pacing also, you want to see the IVS. This is the view that you have to go for. Okay, so you can see the IS in profile. That's how where you deploy a ASD device. You can see the IVS in profile. And this is also the one of the views for a LV angiogram, as well as this also is where the heart is vertical. So this view is the heart is vertical. So you can also see your Seller's AR, quantification of AR in this view. Okay, so these are the segments of the LV angiogram on an LAO view. So as I said, the heart is vertical, isn't it? So here we are seeing the lateral wall, and this is mostly the LAD and circ territories which are in this LV angiogram. So same way, now look at this image. So where is my spine? Spine is to the left. So this is the RAO view, isn't it? So how do the structures look on RAO? So RAO is the view where the heart is en face. So my heart is like this, correct? And if you want to take a RAO view, so suppose this is the projector, I want to see from the right. I have to move like this towards the left. So how will my heart look like? It will look flat on, straight. So in this view, the LV is flattened out. So this is the best view for seeing MR. In Seller's MR, you will see the LA retrograde. And this is the view where the septum is end on, face on to you. Okay. So this is the RAO projection. So this is the LV angiogram in the RAO projection. So here, this top part is the LAD territory. And the basal part comes from the RCA territory. Okay. So this view is the lateral view. The lateral view is also very important. So again, a rough fluoroscopic anatomy of the lateral view is this. Okay. So this is the view where you can see the most anterior structures in the heart are the RV and the PA. So this view you can use to, firstly, we use it for pulmonary valve dilatations. And then we use it, if you see towards the backside, you can see the aorta and PA very properly. So this is the same view where we do PD devices. Okay. So this is the lateral view. So fluoroscopic anatomy understanding is paramount. There is no cardiology or invasive cardiology, whether technician or doctor, without understanding fluoroscopic anatomy. I just kept this because you will all assist your cardiologist in future in TAVRs or other large bore interventions. So it's very important to understand how to take a femoral puncture in the proper place. Okay. So if you superimpose the groin and these are the artery on top of it. Okay. So there are 5 zones they divide. Okay. So you are supposed to hit the common femoral artery. Whenever you are puncturing, you puncture the common femoral artery. So how do we hit the common femoral artery is that the needle or whatever pointer, so you take it on fluoroscopy, the needle should be at the the lower aspect, the inferior border of the head of the humerus, head of the femur, sorry. Okay, so my needle on the skin will be here, and when I take a 45-degree angle and go in, it will puncture here. Okay, so we have to always try to puncture here. Okay, this Rupp's point or Rupp's rule is that the lateral most aspect, the medial most aspect of the head of the femur, you go 1 centimeter lateral to that is the ideal point for femoral puncture. Okay.
If you go higher, what happens? If you go to zone 1, anyone quickly, because I may not get time to finish it in the evening. That's why I'm asking. What happens in zone 1? RPH. Okay, there's more of retroperitoneal hemorrhage because you're hitting high. You may have an inferior epigastric hub. What happens in zone 4, zone 5? You may end up having an AV fistula or having a pseudoaneurysm because you do not have a good point of pressure when you are giving Hemostasis after the sheath is out. Sorry, Subbu. Yeah, go on.
So I think you're all familiar with this anatomy, so I will skip this slide. You just know that the circ has OM branches, LAD has diags and septals, and this is the RV branches. So
One thing that's asked here is what is the bundle branch? What is the supply of the bundle branches? These things are all Yorkers in exam. Supply of bundle branches. Anybody? Upper part by the septal of LAD, lower part by the PD from the RCA.
Okay, so this slide I have kept because it's very important. All of us know that inferior wall MI block happens. So why there is a block in inferior wall MI? It's because of where the AV nodal artery comes from. So the AV nodal artery mostly comes from PL branches, okay, which is very distal. So you have any mid to distal RCA, and most patients the AV node artery arises from the RCA, and rarely it can arise, unless not rarely, in 20-30% it arises from LCX. And the same thing as the SA nodal artery. The SA nodal artery comes from the proximal RCA. So generally, in whatever MI, you don't get SA nodal blocks or SA nodal disease. You get only AV blocks because you don't get such a high cutoff of the SA node. Okay.
What is the first branch of the circ? Anyone? What is the first branch of the LCX? Left atrial circumflex. It goes the other way. What is shown? What is shown actually in the previous slide?
So this is the LA circumflex. So very important for you all to know is this slide because you need to know what is mid LAD, what is proximal LAD. So in short, very simple is that prox LAD is whichever is the first major branch, either septal or diagonal. Before that is prox. Then bend of the LAD in RA view, that is still there is mid, and after that distal. Please understand there is no concept of a mid LCX, that is wrong. So anything before the first OM is prox LCX, then after that is distal LCX. In RCA, the cutoff is the acute marginal. So I'll just show you this. So the acute marginal. So from the entry point to the acute marginal, halfway to that is prox and mid, and distal to the acute marginal till the crux is distal RCA. Okay. So this is important for that. I'll describe each of these standard projections, but what we have to remember is for left coronary, we have 5 views, and for right coronary, we have 3 views. I'll show them, each of them. We have to take multiple views for multiple arteries. Broadly, please remember that if you want to see the LAD straight on in its whole path, you have to take cranial views, right? And in caudals, we see the proximal part of the arteries, and the LAD will be foreshortened. So anything in mid distal LAD, go to cranial. Anything in prox, go to caudals. Left main is good in iliocranials, shallow iliocranials, and left main is also good in caudals, but always foreshortening is less in cranials. RCA, I'll just show you. Okay, so we have different views to profile the left coronary arteries. So I'll just go quickly. So this is, again, it's ariocaudal because, or at least apicaudal because the spine is on the left side of the screen, isn't it? So just to superimpose where the ventricles look like in each view is this idea. Okay, so you see LAD, this thing going down is the LCX, right? So LCX goes in the AV groove. So LA is, this is where it is between the LA and the LV, right? So ariocaudal is ario or apicaudals. They are good for firstly proximal LAD and they're good for the LCX. Okay. Usually nowadays the standard caudal was more 30-40, but we reduce it. Most labs take around 20 so that the effect of respiratory variation is reduced. Okay. So this is another standard view. So anyone can tell which view is this? Okay, so this is the epicranial, standard epicranial. So again, just as I said, in cranials, the LAD is straight, bang on. So where does the LAD flow? It flows in the anterior interventricular groove. So this is roughly where the RV and the LV are. And above, you can see above. So this part. So the thing on top is the LCX, right? So LCX runs in the AV groove. So it's between the LA and the LV, right? So again, this view is best for profiling mid-distal LAD. Okay. So any idea about this view? So you can see the diaphragm very prominently. Yes. So you can see that. Yeah, perfect. So iliocranial we were taught is like the coconut view. You can see the whole heart like a coconut. All the coronaries like a coconut, right? And this again, the iliocranial is very important. Yeah. No, it is not.
What is less? Is it less LA or is it less variable? Because the usual one is this way.
This way, yes.
Not gone as clear as it shows, as LO as it
Yes. So this is a bit less LO. Okay. And why iliocranial is important is that, yeah.
What is about LO thing?
Answer to sir's question is in the video. Look carefully at the LCX. I'll play the LCX for you. Yeah.
Dominance.
Dominance.
Want to look at negative diagonal bifurcation. Third is when you do a CTO intervention, you want to see the right coming from the left. If you have a computer right coming from the left, you can take this. Sorry, so go on.
Yeah. So if you can see very carefully in this video, this yeah, this is less LO. This LCX is giving off a PD, right? So it is a dominant.
I think the question is not.
Yeah.
What's that? This is a dominance, sir.
So this is a left dominant circulation. Okay. Yeah. Yes. Okay, so this is everyone must be knowing this view, because at least even if you don't know what it is, everyone knows it as the spider view. Okay, so this is the iliocaudal view. Okay. So can anyone imagine where are the cardiac structures in the iliocaudal view? So iliocaudal view shows the LA very prominently. Okay. And because the circ is enfast and prominent, so you can see the AV groove very properly. And the iliocaudal view is the best for the proximal left coronary branches. Okay. Okay, so this view again, any idea? So you can see the diaphragm very clearly. So this is a cranial view, right? And see very clearly the spine is on the left. So this is the areocranial view. So areocranial view holds the LAD completely. You can see it straight on, bang on. So it's a very good view for mid and distal lesions. And sometimes oblique areo views give you a bigger idea of bigger and better idea of prox and mid LAD lesions, which are otherwise hidden or overlapped in other views. So now understanding the RCA takes a little bit of imagination. So there are three standard views for the RCA. So the engagement plane is also LAO, and also for most parts of the RCA this is the LAO. But when we want to look at the distal RCA, we need to take cranial views, right? That is what sir was alluding to, because cranial, when you take cranial, so like I said, so if you take the coronaries like this, and when I pull my hand down, so the inferior part of the heart is seen well in cranial views, right? So you take cranial views to see the distal RCA. So if you want to see the PDPL properly, you need to take a AP or a LAO cranial. Otherwise, standard LAO is good for the RCA. If you want to profile eccentric mid RCA lesions, you have to go lateral or take RAO. Okay, so just a brief, I think you all must be knowing it. You can feel free to take these slides. This is the type ABC classification of lesions. You also need to know that this particular thing concept is very important, that how much lumen diameter reduction in an angiogram corresponds to how much stenosis. Okay, so these two facts, please read for the exam. You should know what is a type ABC lesion, and you should know how much diameter reduction corresponds to how much area or lumen reduction on an angiogram. Okay, so this is the TIMI flow grade. Everyone knows the TIMI flow grade. This should be known word to word, line to line. You should know that TIMI3 is normal, TIMI2 is slower than the other normal vessel, and TIMI1 is a very trickle flow, no flow. And this is for epicardial, the big arteries which we see, right? So if you all must have seen, whenever we take an angiogram, particularly we take prolonged shots, we will see blush on the septum, right? Whether LAD or RCA, that blush on the septum. So that blush is filling of the microvasculature. There is a grade for this filling of a normal or abnormal filling of the microvasculature. Please remember that microvasculature is as important as the big vessels on top, and you should have a rough idea of how the blush is graded. Okay. So just a quick run of what are the three main issues which we face in coronary angiography or in interventions is thrombus, then we have dissection and perforation. So thrombus, there is a grading of thrombus. This is just a brief run of that. In short, when you have grade 3 or 4 thrombus, they are large thrombus. You can see them wriggling in the coronaries, and they require to be fixed by thrombus suction. Okay. This is the grading of dissection. Okay. And the one dissections which we are all very worried about, type D and type F. Okay. Type AB happen very regularly in angioplasties when we are dilating with pre-balloons. Okay. This is the Ellis classification of perforation. So you see in this video I'm just showing, this is one of the common times the perforation happens. So you can see staining starting. So they've put a stent and they're trying to post dilate. As soon as they post dilate, you can very clearly see that the stent has been placed and they're starting to post dilate. So you can see the stain starting. At that area, you could have seen the stain starting when they're post dilating. So this is the grade 3 perforation, right? So this is something which we all dread, and probably at least I would also have a MI myself seeing that before I can react to it, hopefully. Okay. So these are some coronary anomalies which you need to remember. The most important and the first one is this. So anomalous LCX from RCA. If someone can tell me without Googling, if can you see this on echo, particularly if it has a retroaortic course, please do tell me. I will personally buy a Parker pen right now and give you in the evening. Anyone knows if this can be seen on echo? Yeah. Yeah, perfect. So you get a pen from me, just remember I'll give you it. Okay. Any other, any other signs for the same thing? You're right, it's a RAC sign. Any other views you can see the retroaortic coronary? It, yeah, dot. That's it. And it's not for, yeah, Parker is gone. No, I'll still, but it's a 5-chamber view, not a 4-chamber view. Okay. You have to open 5-chamber. You have to open the aorta. No, without opening the aorta, you cannot see the retroaortic coronary. Okay. And the most common RC anomaly is the high anterior origin. So you can see that here, normally the tiger should look like this, right? But the tiger is facing forward. This is the anterior origin of the RC. This is the most common anomaly which we see in angiograms. Okay. And whenever we are taking radial, because nowadays this is the era of transradial intervention, this is what radialists they dread. It's not that we are worried about it. You can still intervene. This is the arterial usuria. So arterial usuria, see, normally your subclavian should just enter like this. So your catheter enters like this. But in lusuria, what happens is this right subclavian, it originates from almost near the left subclavian. So when your catheter has to enter the heart, it forms a big loop like this. So you don't get any support for doing interventions. Okay, it's something very difficult to negotiate. So the first pitfall, the major problem of coronary angiogram is it's a luminogram. See, you're not seeing the artery from outside. You're seeing only the contrast inside. So if it's a diffusely diseased vessel and whose lumen is uniformly narrow, you can think that, oh, this looks normal, but it's just a thin lumen you're seeing, right? The other issues are then again, there are many views which overlap. So these are all issues regarding a 2D interpretation of a 3D structure, right? And always remember, someone who's very fatty, the biggest problem you get in iliocordal. You try to take a iliocordal, they'll be like, all Indians, we're all fat, we have abdominal obesity. Nothing you'll see even if you go 15 frames, okay? So this is another thing which we think this is a lesion. Oh my God, what is, so anyone can tell me what is this? Yeah, so very good. So that's a bridge. Bridges are generally treated medically, you should not stent them. No Parker, sir.
Or the tunnel artery. Tunnel, and you have a myocardial segment over that, called the tunnel artery, just in case they ask you all this.
Okay, right. So can anyone tell me this? So I've put an example purposely because this is most commonly seen in.
Yeah, this gets an extra jamun.
Yeah.
What is this? Okay,
So this is normally seen in RCA. I'll give you that hint. I've put it because this is an example where it's not in the RCA. So this is vessel, then somebody has wired it.
Of this.
So Satya Sai students, I would say sir has asked you this in lab 50 times. 50 times it has been asked. In my 8 months of being here, it has been asked 50 times in the lab. So.
Okay, it has a name of a musical art. Tell. This is called as an accordion, also called as
concertina. Yeah. So this is the concertina. So
you have 60 kilos, person weighing 100 kilos. You have this wire. See, he put it after the wire. If you see it nicely, it's laid once. It's not there in the initial artery. It's not there here, but someone wires it. Right? And then those pseudo lesions come. They're actually all pseudo lesions. There's a wire. Comes the tortuous vessel. Now you get this. It's called a pseudo lesion. You don't have anything there.
So it's just like when we wire a bent or a tortuous artery, the wire straightens out the artery. Yeah. This. Okay, so I will try to. So cath lab materials sheath, you need to know you have separate femoral radial sheaths, right? Color sizing, color coding is very standard. At least please know at least till 8 French or 9 French. These colors are very standard, red, gray, green. Okay, so 1 French is 1/3 mm, and for introducer sheets, whatever French gauge we are giving is the internal diameter. Outer diameter is more. Okay, and so these are how sheaths are, and this is for a sheathless guide system. If you want to do radial interventions with large bore axis, you want to take 7 French and all that, so you can do radial. And this is the newest thing in the, not new, it's now fairly old, but the idea is that you have thin walled sheets. So if you want to say take a 7 guide from the radial, usually 7 we cannot take radial, but with this, either we can go sheathless and take a 7 guide, or we can take a thermoglide sheath. Here it's 7 and 6. That is, the OD will be like a 6, so it will fit in the radial and you can pass a 7 guide through it. Okay. So very important is differentiation between a guide and a diagnostic. Yes, ma'am. Yeah. Yeah.
You will
So-
be wanting to recognize this in the exam. They'll
Yeah.
show you these as spotters.
Yeah. So you need to know difference between guide and diagnostic. So this is a diagnostic, right? And this is a guide. Okay. So this number represents the French gauge. This is the maximum wire it can accommodate. This is the maximum pressure in PSI. If you connect this to a power injector, this is the maximum PSI it can take, and this is the length. Okay. So same size diagnostic and same size guide. The only difference is that the internal lumen will be more. So if you take a 6 French diagnostic and a 6 French guide, this is the internal lumen. This internal lumen will be more than a 6 French diagnostic. There's only difference. Whenever you have a catheter, you have curves, right? So this is primary curve, secondary curve, tertiary curve. So this arrow refers to arm of the catheter, arm. So arm is the distance from primary to secondary. All right. And for say, for example, for a JL, if I say JL4, this arm length is not 4, it's 4.2 centimeter. Okay. And for say JL3, it is 3.2. So 3.5 will be half of that, you can calculate. Okay. So these are the standard left catheters. Whenever we are going radial, we use universal catheters. So whenever we are doing diagnostic radial angiogram, we don't have to take like femoral or JL or a JR. With one tiger, we finish, right? So that does left and right. So it's called universal catheter, universal catheter. So Jackie, tiger is the most standard, and please don't call it tiger outside. Like we all call it tiger, but its name is OptiTorque TIG by Terumo. So it's not tiger. Okay, there is nothing called tiger. It's OptiTorque TIG. The standard left catheters are Judkins left and Ibu. Okay, these are the two you need to know. Rest all not required. The JL has very poor backup. XB has great backup, but XB tends to dissect the left main if not well seated. Okay. Same way for the right, you can see support is increasing, more support. So same way for the left, more support comes with XB. Okay. So for RCA, the standard is Judkins right, but very poor support. You want to have more support, you need a AL2 based on the situation. Again, AL2 problem, it can dissect the ostium. Okay. If you have anomalous RCAs which are down facing, you can use MP. The other options in such cases are hockey stick, and you can use a AR2 also, or yeah, hockey stick and AR2. Okay, these are the shapes. So this is how the catheters sit, like when you're going femoral or radial. Okay, so you can see how the AL is sitting, right? So whenever you want somebody disengages the AL, you have to push the catheter down, not pull it. If you pull it, you will dissect the ostium. Okay. Yes, ma'am. So, like guide extensions, you need to know. So whenever the operator has difficulty passing down material and there is tortuosity, you take guide extensions. These are different types of guide extensions. So the main important guide extensions, we have Guideliner and Guidezilla, and these come in French gauges from 5 to 8. So what is important is that which size can take which. Suppose you want to take a rota or a stent, how much it can take. So ideally, a 6 French Guideliner can accommodate most of the things. So these are Y connectors. We have all different makes, but one of the best in the world is this OK2. And these are micro catheters. So most commonly used is fine cross. Okay, we have fine cross and we have Fine cross is the one which we commonly use in our lab here also. So microcatheters, why do we use microcatheters? Not just for exchanging wires, you can also use it for, it's used for wiring side branches and in some cases also to pass the lesion. Okay, so just going to guide wire, you just need to know that every guide wire has a tip and that tip has a particular weight. Okay, and there is coating either hydrophilic or hydrophobic. Okay, the tip weight is very important for you to know because the standard workhorse wires which we use, higher the tip, higher the chance of distal vessel perforation. So normal, the run through and all that which we use are called workhorse wires because we use them every day for standard lesions for normal crossing. You need heavier wires to cross CTO. The normal workhorse wires have tip load of less than 1 gram. Okay, your standard run through NS is 0.7. Run through NS floppy is 0.7, whereas higher wires, stiffer wires, which we use for CTO have tip load starting from 1.5 going all the way till even 4.59 grams is the maximum. Okay, so the standard workhorse wires is balanced middle weight is by Abbott. Then you have run through. Okay, and then cyan blue is also a workhorse wire, and then you have all the CTO wires. Okay, so you just need to know that workhorse wires are standard wires which we use routinely. The tip load is less than 1, and the work specialty wires are can be polymer jacketed. 1 and 2, they have a higher tip load to pass heavier lesions. Okay. Next is coming to balloon. You need to know that balloons can be compliant, non-compliant, and semi-compliant. What is the idea of compliant, non-compliant, and semi-compliant is that when you have a compliant balloon, you keep inflating it, its size will increase, increase, increase. Some balloon can even inflate to 800 ml, 800 times their size. Okay, that is compliant. So non-compliant is that they can go 110 times their size, maximum 110% of their size. So if you take a 3 balloon, so the 3 NC can go to say 3.1, 3.2, whatever, not more than that. But if you take a semi-compliant, that is midway between these two, it can go to 130% of its lumen size. Okay, so what is the, why do you need these non-compliant balloons? You need NC to exert more pressure without increasing in size. So you have lesser chance of vessel puff, but you are giving more pressure, right? So last bit on how do you treat coronary calcium? No? So everybody is worried about calcium. So as technicians, you are all going to handle all these equipment and give them to your doctors. Okay. So then you have normal NC balloons you want to give for fibrotic and calcific lesions. Then you have cutting balloons or scoring balloons, which have these wires on top of them to crack the lesions. And then everyone knows rota. I'll show you the rota setup. And then we have IVL. And then there's a specialty OPN balloon which can give pressures of 40 atmospheres. Okay, up to 35 to 40 atmospheres. Now, one small question is, can anyone tell me how much is 1 atmosphere equal to 1 PSI, or how many PSI is 1 atmosphere? Pound square inch, you know, right? So 1 atmosphere is roughly 14 PSI. So how many PSI do you put in your car tire? Maximum 30, 32. So that is 2.5 atmospheres. We inflate coronary lesions at least 8, 10 atmospheres. So can you imagine that the coronary is more powerful than a car? Okay. So angiosculpt is, this is a kind of scoring balloon. You can see wires on top. The cutting balloons, drug coated balloons, you should know because now they are in vogue for treating arteries which are small where you can't stent. Okay, they'll have paclitaxel or something on top. So this is your OPN balloon. I didn't put a photo, but the OPN balloon has its own indiflator, which is different. It's black and purple in color with a lock. Okay, this is your IVL balloon. Okay, so IVL console is very simple. IVL balloon, the biggest problem which you all need to remember is that if you're assisting your doctors and doing a case with high calcium and wiring is difficult, even initial balloon passage is difficult, IVL is a bad choice because IVL balloon has a big profile. Crossing like a tight lesion with an IVL balloon is a problem. IVL comes in 2 to 3.5 sizes, but its crossing profile is a relatively bulky balloon. So if there is difficulty in tracking down something, rota is always better. So this is the rota setup, which you all know. So there's a hand console, you have the foot pedal, this is the pressure. So what is the gas we use for rota is nitrogen gas, right, for pressurizing it. And apart from that, you need to put a flush system. Okay. Ideally, you're supposed to use a Rotaglide. They have a proprietary flush system, but we don't use, we use NS. Okay. So this is IIBP. You are all familiar with IIBP. Okay. So the standard IIBP balloon require, if it's you're using an NY at 8 French should be fine. If you're using OX, you need 9, 10 French. Okay. Helium gas is used in IIBP. Can anyone tell me why helium gas is used? Why not any other gas? Huh? So helium is inert, right? So if suppose a balloon bursts inside your body, nobody is going to die with it. Okay, that's why. So this is an IABP trace we should know, and IABP augments diastolic. So you should know that the diastole is augmented. This can be 1 to 1, this can be 1 to 2 or 1 to 3, as you can see in the machine. Okay, the machine gives you both augmented and non-augmented, correct? Just a short last thing on stents. So you need to know that in the present day, okay, first they were bare metal, then first generation, second generation. Most important you need to know is in today's world, okay, when you are assisting your doctors, you have DP DES and you have BP DES, okay, durable polymers and biodegradable polymers. So what is the idea of biodegradable polymer? The polymer is going to absorb fast. Within 3 months, the polymer is gone and it's going to behave like a BMS. So your doctors will prefer this in patients whom they feel are at high bleeding risk, cannot give antiplatelets for a long time. Which are these BP DES? Because currently the best BP DES in the market has Synergy and Orsiro. They're both FDA approved. Okay. Among the Indian stents, Supraflex Cruise is a terrific stent. Okay, is manufactured by SMT, but it is not yet FDA approved. It's only CE marked. That's why still okay. All the other, I'm sorry, this Onyx is also a BP DES. This is wrong here. Okay. So DP DES are the old Zion, the Zion's Expedition. Now Expedition out of the market. That's it. Okay, thank you, and Sairam.
You made my job a lot easier for the afternoon.
Really, thanks Subramanya for making the talk very interesting. I hope you all enjoyed this talk, and he's given you really all the basics and much more. I just stopped Dr. Subramanya a bit because I said we were short of time, so I didn't allow him to cover a few more details. So I said, he was trying to teach you how to hook a nail and things like that. So I said, no, they may not do it. But let me be very honest with you, an experienced technician is better than a fresh doctor. We were told this when, 25 years ago, we were doing internship. We were told an experienced nurse is better than a fresh doctor, and that is the truth. So when I started my punctures, and even if today I want to hook a coronary, not today maybe, but when I was starting off, if I was not able to hook, the technician would guide me. Press karo, ye karo, shall I go LAO? They give you hints. That is how good you will all be. Today we don't have time to dwell, but please remember, if you learn the tips and tricks, you will all be able to guide the doctors in a much better way.